Hello, everyone, and thank you for joining us again for Saturday Conversations Talk with a Doc. Today, we are honored to have a special guest with us, board certified medical oncologist, Dr. Martin Dietrich with Florida Cancer Specialists. Dr. Dietrich, we're so glad that you could join us. Genomic profiling, I know that that's a big issue for you. So, in layman's terms, explain to us what that means and how important that is in terms of the breast cancer fight.
So genomic profiling is not just the blueprint sequencing of a gene like we do for BRCA1 or BRCA2, but really looking at the network of genes, how they interplay. And essentially what those genomic scores are looking at are at a fingerprint of aggressiveness and a fingerprint of chemotherapy benefit. So we're looking at chemotherapy mostly benefiting disease that is more aggressive, disease that is more responsive to it. And we want to make sure that every patient gets what they need, but not more. As you know, chemotherapy and other interventions in oncology always have a meaningful amount of side effects. We always want to make sure that we don't overtreat. We don't want to undertreat, we don't want to overtreat, and these genomic tests are helping. We've seen a second frontier, and that is the genomic testing that has arrived in the endocrine therapy space. So when a woman is on tamoxifen or one of the aromatase inhibitors for suppression of hormones that are driving cancer, oftentimes the subjective experience of joint pain, fatigue, lack of energy is pretty meaningful and leads to a concern. And then we would really like to tailor how long the benefit of endocrine therapy is. Do we need to extend? Typical recommendation is 5 to 10 years, but it really varies between the different subgroups. And we've also had a lot of changes in the guidelines with regards to utilization of genomic testing in the endocrine therapy space. So we're really trying to personalize the approach to medicine for patients to make sure that we balance the benefit of a patient with the side effects in the most categorized way that fits the individual situation best.
Is the goal here eventually to design a treatment for a patient that is just specific for their specific cancer or tumor?
So, and that's what we're working on. We because of the nature of our studies, we have to find some common umbrellas that group certain sets of findings together for patients. But the idea is to really individualize therapy to the point that no one treatment looks alike. I get this a lot in clinic, that a patient comes and says, well, I'm being treated with this. My friend had this treatment, and I'm wondering why is it that I'm receiving a different treatment or additional treatment? What is currently creating confusion is hopefully soon the new standard for all of us, that we have no longer this one size fits all stretch pants approach, but that we really have nicely tailored individualized solutions.
And so how soon might we see that?
Well, we've seen some of that progress. I'll give you an example. When I started oncology in the mid 2000s, the percentage of women that received chemotherapy following an original surgery was about 80 to 90%. We're down to about 15 to 20% without worsening our outcomes. We've significantly moved the needle in the direction of less chemotherapy. There is progress, so there has been already some impact done, and I think we'll refine this in multiple different spaces. We're already seeing the genomic profiling in radiation therapy, for example, for early ductal carcinoma in situ, the stage 0 precancerous lesions. We're seeing that radiation is using more and more genomic testing, and then also in the endocrine therapy space. So this is already happening and part of the guidelines. I'm saying that we're already at the end of it. I don't think so. I would like to see tests that go even further and tell us when endocrine therapy is actually not necessarily helpful at all. If we see low risk early stage disease, the concern of overtreatment there is always there. We extrapolate and say, well, if a tumor is very small or very low risk, do we have to treat it like a higher grade tumor that is more characterized. And that's actually part of the benefit and part of the challenge that early screening has. Sometimes these tumors are discovered so early now that we don't really know what to do with them. Yeah, there's going to be a lot more research and a lot more effort in de-escalating therapy. Those are the major objectives. But I can assure you there has been so much progress already that it's really exciting to see that shift going on the last couple of years.
For people who are current patients, what's the latest on clinical trials? What's most exciting?
Right. So there are a number of developments. I think a big focus is currently the space of hereditary mutations and so predisposing mutations. And everybody has heard of the Angelina Jolie BRCA family of genes, BRCA1 and BRCA2, that have basically an exceedingly high risk of breast cancer development. Looking at related genes, ATM, ATR, the Fanconi family of genes. Without going into the details, we've really moved into broader panel testing. I think it would be, and this is why work from advocacies like yours is so important, to help us allow screening women, all women with breast cancer, to receive this screening on what we call a panel testing up front, to really decide what treatments may be done. My favorite cancer to treat is the cancer that I don't have to treat. So if I have somebody who had an early stage cancer and we are able to get genetic testing approved, which is always a challenge, and we can intervene prophylactically, this would be a wonderful part. But these genes not only have a prognostic impact, like that tells us whether or not cancer will develop, but they also pose a vulnerability in the DNA repair complex that will help us to actually treat a patient. We'll see this for triple negative breast cancer. We already see this in the metastatic space for hormone receptor positive disease. And basically what we're helping the cancer to do is a cancer that already is prone to errors and error accumulation, to basically trip, stumble and fall and eventually shrink or possibly even go away. So we'll see that this is going to be important. In my opinion, that's the biggest chance for us to help women advance care, and as the most immediate next step is to just allow us to utilize in technologies what we already have without the restrictions from payers. And we're trying to be very proactive. We've recently established a genetic counseling service in our facility, where we basically use telemedicine as a way of reaching patients in the comfort of their home, trying to identify risks, a person inside the family at risk, and also within one patient, individual measures that can be taken to prevent not only breast cancer, but possibly other cancers. There's a correlation between breast and ovarian cancer, and depending on what the genetic setup is, these correlations are very strong and should be offered really to everybody. Unfortunately, this has always been an uphill battle for approval.
When we look at hereditary, do we just look at the mother's side of the family, or do you need to be looking at what's going on in your father's side of the family as well?
So I have to tell you, the best population genetics that we have comes from the rural population of Nebraska. Dr. Lynch, who unfortunately passed away, was one of the pioneers in the field of population genetics. He had large Nebraska farm families to work with, where you had 12 siblings, and basically you knew parents and grandparents and great-grandparents and their medical history. So he was able to draw very good pedigrees. We don't have that possibility in many times. So my feeling is, in the 21st century, we should utilize 21st century technologies. Paternal side is as important as maternal side with information. Oftentimes, this information is insufficient or scanned, or patient's parents are deceased and it's not really clear what happened. Oftentimes, in earlier times, there wasn't any workup done if cancer was involved. So I would start with a genetic test and combine this with the information of family history. But the paternal side is actually the more dangerous one, because a predisposing mutation like a BRCA1 leads to breast cancer in women at 80–90%, while it is 1 or 2% in men. So they may be the silent carriers, and that may be a ticking time bomb that is unidentified, so that the paternal side is just as important, if not the more concerning side.
Once a patient has finished treatment and has crossed that important 5-year mark that we think is, okay, we're good, should you always continue to get a yearly checkup in terms of trying to get an MRI or a CT scan or tumor marker test? How long should you do that? Is the answer forever, or 20 years or 50 years, or what?
So that's a question that Florida has a very interesting perspective for, because what I've seen in my age expectations in Florida is something completely. I see 90-year-olds playing golf every day. So for just typical recommendation, stop mammograms at 75, or don't. My toenails curl. This is once you've been diagnosed with cancer, I think follow-up should be at least annually for, in my opinion, the remainder of your life. I don't see there's a reason. That the type of imaging really depends on the individual patients. There are some women that have very good screening results with just a mammogram, sometimes complemented with an ultrasound. There's some women that have complex, dense breast tissue to analyze, and then an MRI may be helpful. This should be complemented, in my opinion. Still the most sensitive and most frequent mode of detection is the self-exam, and this is heavily discussed. I cannot tell you how many women I've seen that have discovered their breast cancer themselves, and much earlier than a mammogram has. And oftentimes they feel a lump, and the mammogram doesn't see it. So they would have been, without that clinical part, been undiagnosed if they hadn't insisted. And so there is, in my opinion, not an age where you should safely stop. I do transition a patient at 5 years in my mind from a active treatment into a survivorship category. And I think that's important from a not only from a physical recovery standpoint, but also from a emotional, psychosocial standpoint, to be in the spirit of I fought and I survived this cancer. But age is a really poor prognostic. Like advisor in this setting, I have 24-year-olds that had new breast masses, and they were basically not taken seriously, and it was through their insistence that a workup was actually done, sometimes through change of physician, sometimes through really a lot of pressure, and there's certainly not a cap in age at the top. My feeling is that somebody who had breast cancer has already seen the benefit of early screening and early detection. We know that outcome is stage dependent, and there should be no, in my opinion, there should be no guideline. The 75 is based on the average life expectancy of 78 for women. So that is the rationale of the U.S. Preventative Task Force to cap. In my opinion, it is not one that really applies to real life by any means. And I would feel really bad if a patient would get undiagnosed. And the tumor markers are a little bit different discussion. There's some that say don't do them, especially if they were positive in the beginning. I think they're reassuring. And I think we have to see that we're not only treating the body, but the mind at the same time, and have that information available. So if a patient had them done, I definitely continue them. I think it's a change in gear. And in my opinion, they're not very expensive. They're very easy to obtain with a lab draw. So I do continue them, and I don't feel strongly about not utilizing them.
So let's transition now into something that you want to talk about here with Florida Cancer Specialists, and that is the foundation. So what does the foundation do, and what does this mean for patients here in Central Florida?
Right. So as you know, cancer is a disease that not only affects the medical category of your life, but it affects your work life, your ability to earn an income, especially when you're on active treatment. There are other factors that may come with it, and it puts oftentimes not only the patient but the entire family into a difficult and challenging situation. The incentive behind the Foundation for Florida Cancer Specialists was to help proactively and fill in for patients that are undergoing active treatment, and to allow them to focus on active treatment, to help if there are areas of need, whether it is a concern about transportation or concern about a rent or a mortgage payment, and help patients to basically be able to continue to the best extent possible to focus on their treatment. So that was the spirit behind the foundation, and the physicians at Florida Cancer Specialists have been basically joining together and say, well, we'll support the foundation, not only through donations, but also the staff and overhead, so that anybody who gives to the Florida Cancer Specialists Foundation can be assured that 100% of their donations are actually being received by patients, and that there's not any friction loss in the passing through the foundation.
Well, we were very excited when we heard about that, because we have a similar mission. And so we're glad for this partnership. So when people hear about this, the next question will be, how do you apply for help through the foundation? So how does one apply?
Right. So in our settings, when we have a patient start treatment at our facilities, they always meet with the financial counselors. I think it's important to have a sense of transparency and a sense of being able to plan for what is to come. And this is already the connection point for the financial counselors to start the process, the screening. Is there any assistance that we can give, or that we can get through a drug access program or other support systems, and really have a comprehensive financial evaluation to provide the best extent possible. I mean, they've coined this term of financial toxicity of cancer treatment, and it's been in the, as you know, it's been in the news that we've been discussing a lot of these healthcare impacts on patients, and the concern about how you balance one's employment, which is for many the source of their health insurance coverage, with somebody's need to focus on their health and their medical needs. And I think this is where the private foundations really play such a pivotal role in helping patients to be able to do what they need to do, so that there is a perspective of positive outcomes, and that they can focus on managing their side effects or their need for treatment, and don't have to worry about where they're going to sleep next month.
So this is just for patients there at Florida Cancer Specialists, correct?
That's my understanding. I know we've been working together with other groups when there have been collaborative efforts, and the patients that have been seen in our facility for clinical trials, and they go elsewhere. So once you've been in touch with us, you're always going to be a patient, and that is access for patients that are being supported. Yes.
And you talked about this a little bit, but as a physician, how important is it for you in treating a patient where you can say to them, okay, here is one less thing for you to worry about. Concentrate on treatment, because you're not going to be evicted.
It is of enormous importance. There's nothing more heartbreaking, and unfortunately, we've all seen that, and that especially in times of COVID, we've had major layoffs in the tourism industry, and loss of health insurance coverage, and patients that are then struggling to survive, really compromising their treatment, is one of the most heart-wrenching things. I'm a physician and scientist. I'm not a financial expert by any means, but it is heart-wrenching to see that we don't have that kind of comprehensive safety net for everybody. I think it's great that you and also our foundation are doing what we can to do our part to be as supportive as possible. I don't know that there is a public source that is able to do this, so I think if as long as that's not the case, I think the private foundations will be the cornerstone of patient support. And I said there's always more that can be done, and as you know, this was a year where many of the charity events, where many of the of our typical donors were oftentimes undergoing their own struggles, and so we've had a setback in the foundation that like many other charities as well. So hopefully we'll be able to regroup and regain that strength to the best extent possible, so that we can continue our missions. This year, the physicians at Florida Cancer Specialists have filled in to make sure that we can continue operating like we have in the years before, and we hope we can maintain that in the years to come.
So as we close, how can people find you? Someone who is looking for a medical oncologist, how can we find you?
Well, I'm currently practicing in Lake Mary and in Altamonte Springs. We are actually opening up a big facility in Lake Nona in conjunction with the University of Central Florida and also the Sarah Cannon Cancer Research Institute. So we are partnering with a number of close collaborators that are helping us to provide the full spectrum in Central Florida. We are in a unique setting. We don't really have a big academic medical center in Orlando, so we're kind of used to send patients traveling and say, well, you have to go to Miami, or you have to go to Houston or to Atlanta. Now we have the opportunity to bring what is needed here. So there's a lot of local progress and a lot of development that has been helpful. I always encourage having those additional opportunities. You asked earlier about the progress. Without clinical trials, the ability to provide what is really tomorrow's standard is really, really challenging. And I really encourage that evaluation for every patient at the beginning of their treatment course. And along the way, things change. What we knew in 2010 is outdated compared to what we do in 2020. So I think those are great sites. And you'll see in January, when the big University of Central Florida Cancer Center will open, that this is going to provide a whole new set of opportunities for patients in the Central Florida area.
All right, Dr. Dietrich, thank you so much for joining us today.
It was a pleasure. Thank you so much for having us.